Dear students, today I'm going to tell you some important things about neonatal jaundice and hemolytic disease of newborns. Before to talk about pathology, let's remember some important issue about erythropoiesis and physiological jaundice. During the development, we have changes of the site of erythropoiesis. First of all, RBCs and general blood cells are producing in the wall of the yolk sac, then in the liver and spleen, and finally, after 24th week of gestation, in the bone marrow. Hematopoiesis process is regulated by erythropoietin level and stimulated by low oxygen tension during intrauterine life. At 40th week of gestation, so in full-term pregnancy, normal infants have cord blood hemoglobin 19 to 22. Fetal red blood cells has a shorter lifespan, maximum up to 90 days. I remind that RBCs carrying hemoglobin A have lifespan up to 120 days. High oxygen affinity allows fetal RBCs to get oxygen from mother's RBCs. That is very important for tissues oxygenation during pregnancy. But high oxygen affinity after birth results in poor tissues oxygenation. That's why hemoglobin F must be replaced into hemoglobin A carrying RBCs. So happens physiological destruction of fetal RBCs carrying fetal hemoglobin. There are two sides of RBC's destruction, two sides of hemolysis, intravascular hemolysis and extravascular hemolysis that happens in liver and spleen. During pregnancy, free bilirubin is transported to mother through the placenta for metabolization and excretion. After birth, maternal system is not longer available to remove and excrete bilirubin, but neonatal liver is not fully functioning. There is related deficiency of albumin and ligandin and glucuronidinotransferase, so this results in physiological jaundice. Physiological jaundice is absolutely normal condition in the first months of baby's life. Reasons are changes of RBCs type from fetal RBCs to adult type of RBCs, shorter lifespan of fetal RBCs, high erythrocyte mass in neonates, so in older period they don't need it anymore, so some RBCs will be destroyed, and not completely functioning liver, low hepatic excretory capacity. That results in physiological jaundice. Physiological jaundice appears between 48 and 72 hours of life, so average is third day, possible from second to fourth day. Maximal intensity on day 5 to 6 in full-term neonates. Total serum bilirubin usually doesn't exceed 12 milligrams per deciliter in full-term neonates. In some literature, you can see a little bit different maximum limits, 12, 15 also possible, 12 to 15. From 15, it's already indication to start the treatment between 12 and 15, so we have a question we need to check. If it is below 12, absolutely normal, we are not worried. If between 12 to 15, so there are some questions, we need some further examination. Physiological jaundice completely disappears after 10th to 14th day of life. So it lasts about 10 days. and no treatment is necessary. In other courses, in general therapy, in the course of surgery, teachers told you that jaundice is a pathological symptom um, presenting as yellow discoloration of skin, sclera, mucous layers because of high bilirubin levels. Yes, really, there is only one period in our life when jaundice can be physiological. It is neonatal period. So newborn baby may have physiological jaundice. Most of newborn babies have physiological jaundice. But unfortunately, there are many conditions when in newborn baby jaundice may be pathological. The primary task of general practitioner, of the family doctor, um, is to define when to be worried, when to think about pathological jaundice. If the baby is having normal weight gain, he has full, complete gestational age, he is absolutely healthy, no associated infection, no negative neurological symptoms, reflexes are normal, urination is normal, stools is normal, reflexes, muscle tone, everything is normal. The baby is just yellow. Okay, more likely it to be physiological jaundice. If you see that something is going wrong together with jaundice, always check the baby. Maybe it is just some concurrent condition. Maybe they are not related to each other. Maybe yes, maybe no. Your primary task is to suppose when to think about pathological jaundice and to check the baby on time. As you see from this table, we have cases of indirect hyperbilirubinemia and direct hyperbilirubinemia. Today we will talk in details about a case of indirect hyperbilirubinemia related to RH and ABO incompatibility and minor blood groups incompatibility. So when Coombs test is positive, when we have immune reasons of hemolysis. But look in this table very carefully. There are many, many reasons when we can see pathological jaundice in newborn babies, starting from hematological diseases like spherocytosis, elliptocytosis, and others, genetic conditions like Crigler-Najjar syndrome, to malformations like bile tract atresia and others. So very, very different reasons. How to define? First of all, the time when the jaundice appears. If you see the jaundice in first 24 hours of baby's life, you have only one option. This jaundice is pathological. Look in the middle. So from second to third day usually presents physiological jaundice, but there are some cases when it can be pathological. Late appearance or persistence of jaundice long time after third week of life usually tells us about pathological conditions. Hemolytic disease of fetus and newborn, another name erythroblastosis fetalis, HDN, HDFN. You can see different names in different sources of data. Also, you see the code in International Disease Classification. What is it? It's an immune condition that develops in the fetus when immunoglobulin G molecules for babies' erythrocyte antigens are produced by mother and they pass through the placenta, these antibodies destroy fetal RBCs in the fetal circulation, and this destruction leads to anemia, hyperbilirubinemia, and sometimes severe hydrops. So it's autoimmune condition develops because of blood groups incompatibility between mother and child. Before to talk about incompatibility, let's remember what is blood group. On our RBCs, on the cell wall of our RBCs, we have specific substances that are called antigens. And immune system can respond on these antigens. It doesn't respond. Self-antigens or our antigens. And it reacts on the foreign antigens. The membrane of each red blood cells contain multiple millions of antigens. Normally, if it is our self-antigen, they're ignored by our immune system. But if we have a contact with any foreign antigen, our immune system will produce antibodies against this antigen. The antigens expressed on red blood cells determine our individual blood group. There are two main blood group systems. They are called ABO system with blood group types AB, AB, and O, and RH system. 5 main RH antigens we have on red blood cells. We have RHC, big C, RHC, small c, letter RHD, and RHE. The presence or absence of antigens on the red blood cells is very important when we have a mixture of blood from different individuals. It can happen in case of blood transfusions, in case of organ transplantations, and during pregnancy, when it is possible the contact between mother's blood system and fetal blood system and the immune system of mother. ABO system and RH system, they are called major blood groups because the majority of antigens on the RBCs, they are from ABO or RH system. But also we have other antigens and we have minor blood groups that determine our blood. So most common minor blood group antigens that lead to blood incompatibility between mother and baby include Cal system, Duffy, Diego, Kidd, and MNS antigen system. 3 of them are associated with severe hemolytic disease. They are anti-RH-D antibodies, anti-RHC, and anti-Cal antibodies. These antibodies are associated with severe hemolytic disease. ABO hemolytic disease can range from mild to severe, but usually it is mild to moderate. RHD hemolytic disease is the most common form of severe hemolytic disease. I remind you which antigens and which antibodies we have in ABO blood group system. So, hemolytic disease usually happens if mother's blood group is O, so no antigen on the RBC, but antibodies are present, anti-A and anti-B. So, if baby's fetal RBC carrying A or B antigen comes to the mother's circulation, mother's immune system produces antibodies IgG. They cross the placenta and they can destroy fetal red blood cells in the fetal circulation. Pathophysiology of RH conflict is a little bit different because RH incompatibility happens if mother is RH negative and the fetus is RH positive. RH negative, it means no antigen and no antibody. Mother's immune system never met this antigen before. So, in the first pregnancy, if the fetus is RH positive, mother immune system has primary immune reaction. Mother becomes sensitized to this Rh antigen. Usually, first pregnancy is safe. Not first baby, because first pregnancy may finish in different ways. Not only in the delivery, it may be abortion, it may be miscarriage. So first pregnancy is usually safe. What happens in the following pregnancies? If the second or following baby is Rh positive again, it is repeated contact with mother's immune system. And we have very fast production of IgG by mother. Immunoglobulin M is small, it can cross the placenta, attack fetal red blood cells, and destroy it. And in the following pregnancies, Rh conflict becomes more and more severe if fetus is Rh positive. If the second or following baby is Rh negative, nothing will happen. Only if mother is Rh negative and fetus is Rh positive. There are three clinical forms of hemolytic disease. It is anemia, jaundice, and hydrocephalus. Also, unfortunately, in some situations, in severe cases, can happen intrauterine death. So, sometimes a baby, usually first baby, can be absolutely healthy. The most common form is jaundice form. To think about jaundice form of hemolytic disease, we must, if the jaundice appears within first 24 hours of the baby's life, or if we see very fast increase in the bilirubin, more than 5 milligrams per deciliter in 24 hours. In addition to this, we must suppose jaundice form if we see yellow baby and in the family history in previous children happened hemolytic disease. The main symptom is jaundice. Jaundice can range from mild to severe depending on bilirubin level. Always jaundice appears within first 24 hours. It is special for hemolytic disease. Severity grade depends on the level of bilirubin, on severity of hepato and splenomegaly, and increase of bilirubin. We have an option how to how to suppose the severity grade of jaundice just from the time of clinical examination, because we can't take blood sample, serum bilirubin for every baby. It's invasive procedure and it depends on the insurance politics in your country. But on the visit, just from the first look, you have an option how to define severity grade of jaundice. This is clinical assessment. It is called a Kramer scale. It is not only used in Russia, it is used all over the world. Doesn't matter where you will work, you can use this assessment system. What is the idea? The idea is that different parts of baby's body change the color in different bilirubin levels. Remember, I said that usually in physiological jaundice, bilirubin level is not more than 15 milligrams per deciliter. Look at the table, please. In which zones we can see this jaundice. So, first zone, head and neck, bilirubin level less than 8. Upper trunk, bilirubin level less than 12. Lower trunk, so below umbilicus, bilirubin level less than 16. So first, second, and third zone can change the color in physiological jaundice. If you see that forearms and ankles are yellow, and especially if you see yellow palms and soles, these areas change the color in high bilirubin levels, more than physiological range. So you must be very worried, and you must understand that this baby needs some more tests, maybe invasive test or at least transcutaneous bilirubin measurement, but they need further examination. Like in this picture, you see 4 babies. You see all the babies are yellow, but they are differently yellow. In the first baby, this baby has mild jaundice. You also can understand it on the basic skin color. You see that basic skin color is pink. You see pink lips. The second baby has more intensive jaundice. You see his face, chest, abdomen is yellow, but palms and soles are pink. Hips are pink. His lips are pink. So they're pink and yellow. Also, you see the position of the second baby. It is flexed position, normal for the newborn. And look at the lower pictures. These babies are also yellow. They have jaundice, but they're absolutely differently yellow. When you see their basic skin color, it is pale. They are pale and yellow. Paler, it's a symptom of anemia. Also, look at the intensity of yellow color on their skin and look at their hands. Jaundice reached fifth zone of Kramer scale. This zone usually changes the color if bilirubin level is more than 18 milligrams per deciliter. This is a dangerous zone. What can happen? Can happen complications. Acute bilirubin encephalopathy. This complication happens if the bilirubin level exceeds 20 milligrams per deciliter. In these concentrations, bilirubin can pass through the brain barrier and attack the brain centers, brain tissues. There are 3 clinical phases. First phase, it is a hypertonic phase with poor reflexes, poor feeding, central nervous system depression up to coma, muscular hypertonia. Second phase, it is a hypertonic phase. When you see seizures, arching of the body, when you see fever, fever not related to infection, fever because of possible damage of thermoregulation center. Third phase, it is recovery phase, where when we see formation, so when happen chronic changes. As you see in the table, in this small table, you see association between levels of serum bilirubin and the risk incidence of kernicterus in RH conflict. Some patients cannot survive. Everything depends on bilirubin level. Some patients can develop chronic bilirubin encephalopathy. Some patients may recover without any consequences. It depends, and there are no option to predict what will happen. Of course, if you see the patient with extremely high bilirubin level and with severe symptoms with associated breathing problems, circulation problems, everything depends which centers in the brain were damaged. So this results in outcomes. The second form is anemia. Prolonged hemolysis leads to anemia. You can see enlargement of liver and spleen. You can see weakness, pallor, poor appetite, and other symptoms usually associated with severe anemia. In anemic form, you will not see hyperbilirubinemia because all the bilirubin, all the RBCs were destroyed that were possible to destroy, and bilirubin was excreted during pregnancy. So after birth, you see the result, you see anemia. Hydrocephalus, it's the most severe form if the baby was born alive. it results it is a result of extremely high level of antibodies, of the massive antibodies attack when we see massive destruction of RBCs, severe hemolysis in the short period of time. It is a total body swelling. In addition to this, respiratory problems, breathing problems, circulation problems, hypoalbuminemia, enlargement of liver and spleen. So it is a total body swelling. Liquid is accumulated everywhere. It is ascites, maybe pleural effusion, maybe pericardial effusion, maybe accumulation of fluids in the brain ventricles. It is the most severe form. Some patients die from heart failure, from severe breathing problems because lungs were compressed by ascitic fluid, by enlarged liver and spleen. Lungs are undeveloped, so that's why these babies have breathing problems, circulating problems, and of course severe hyperbilirubinemia. There is no mild form of hydrops. Hydrops is always severe. It is severe anemia and severe hyperbilirubinemia. So in hydrops, we also suppose brain damage, and outcomes depends on this damage. How to make a diagnosis? In the diagnosis, we have several steps. First of all, I remind you the name, hemolytic disease of fetus and newborn. All the pathophysiology happens during pregnancy. In the newborn baby, we see the result. That's why diagnostic must be started during pregnancy, prenatal diagnostic. In the prenatal diagnostic, very important is history. We must get in details about number of pregnancies, about the health of previous children. Maybe they had prolonged jaundice. Maybe a mother had miscarriages or history of some congenital liver diseases. Maybe a mother had any health problems that are possible, we must get in details. Probably they are related to current conditions. The most important are presence of genetic related conditions and number of pregnancies and of course number of children and their health. Then we have step of serological tests. Very important is blood group typing for mother and father. Why for both? Because if we know blood groups of both parents, we have options for the fetus. We can suppose which blood groups are possible for the fetus. If we see that a woman is Rh negative, we will be very, very worried. But if we know that a father is Rh negative too, there is no risk of hemolytic disease in Rh incompatibility. So that's why it's important to know blood groups of both parents. Then the step of antibody screening. Antibody screening by Coombs test. During pregnancy, it is indirect Coombs test with mother's serum. If Coombs test is positive, we must identify the level of antibodies. The titer of antibodies is important. If it is less than 1 per 16, we should repeat it every month because increasing level of antibodies, it means increasing risk of hemolytic disease for the fetus. Ultrasound is a standard screening procedure during pregnancy, but it is not so informative. Of course, we can measure the level of amniotic fluids, we can see the placenta, it may be abnormally large, but really informative it is only in case of hydrops, when we see enlargement of liver and spleen, when we see ascites, skin edema, If it is jaundice form or anemic form, we can see nothing. Or maybe enlargement of liver and spleen, maybe enlargement of placenta, or increase in amount of amniotic fluid. No specific findings. If the level of maternal antibodies is greater than 1 per 32, or fourfold increase in the titer, it is indication to make amniotic fluid testing. So amniotic fluid test by amniocentesis. Then after amniocentesis, therapeutic plan can be determined. Amniotic fluid testing, not for all patients, not for all pregnant women. It's a very invasive procedure with high risk of miscarriage, and it must be performed only in case of indications. Indication is increased titer of antibodies. If we see high level of maternal antibodies, it's a reason to make amniocentesis. Not in all cases, not in all cases when we suppose. Another reason to perform it is case of hemolytic disease in previous child. So to identify, to clarify the risk for current pregnancy, we also can make amniotic fluid testing. What we check in amniotic fluid? We check the level of bilirubin. We have specific scales. We have Lillie scale and Keenan scale that determines the risk according to bilirubin concentration in the amniotic fluid. For example, on an example of Lillie scale, so zone 1, it is mild risk or unaffected baby. Pregnancy may progress to full term and no specific interventions are necessary. Zone 2, it is moderate risk zone. We should monitor the level of antibodies every 2 weeks. Pregnancy may be prolonged up to 37 weeks or depending on the result of the following measurements. Zone 3, severe, it is a high risk requirement in the treatment or inducing of labor. So we can make a decision about future therapeutic measurements, what to do, how to treat the fetus. After birth, postnatal diagnostic. Blood group typing for the baby. To make a diagnosis, we must confirm that blood groups of mother and child are different. Also, Coombs test. For the baby, we make a direct Coombs test with baby's RBCs. So we must confirm the presence of antibodies, the immune etiology of this hemolysis. Transcutaneous bilirubin measurement can be used as a screening procedure to detect hyperbilirubinemia. It is fast, non-invasive, can be repeated many times, not disturbing for the baby, very fast, and available even in outpatient clinic or in newborn nursery. Very simple. But it is not to make a diagnosis. It is only to define babies that need additional tests. Blood test for the newborn, biochemistry for jaundice, bilirubin, total bilirubin, direct bilirubin. Also, we must make a liver function test to be sure that it is not a direct liver problems. We must check for protein level, especially albumin level, because low albumin is related to edema and it decreases the capacity to convert bilirubin. CBC. In CBC, we must know the level of RBCs. Also, morphology of red blood cells, presence of erythroblasts, reticulocytes, leukocytes and erythrocyte sedimentation rate to check for infections, because infection, especially torch and sepsis, it's a reason of jaundice, can be associated with jaundice. A blood test for mother we done during the pregnancy, so check for bleedings. It's very important point, because additional birth trauma like cephalohematoma, for example, it's a source of destroying blood. If we have a source of destroying blood, bilirubin comes up. Check for gastrointestinal tract obstruction, so make an abdomen ultrasound, look at the stools and urination. Maybe the presence of uncolored stools can tell you about bile tract obstruction and so on. So check for GIT obstruction. Genetic tests and specific immunological tests we need only if previous simple test didn't show you the reason of jaundice. So it is not a routine test, routine procedures, because they are expensive and they're available only in limited number of hospitals. So that's why it's not a routine procedure. And I wrote it in the last step. If all above didn't help you to make a diagnosis, you can make genetic tests. How to make a transcutaneous bilirubin measurement, usually on forehead and on the chest, where we have, in fact, on the skin, some underlying tissues and bone. How to treat? Treatment depends on the severity and on the form of hemolytic disease. We have three methods of treatment of hemolytic disease. It is phototherapy, it is exchange blood transfusion, and the use of specific immunoglobulin. Also, we can use additional methods, let's call them symptomatic treatment. They are very important, sometimes critically important. They are very useful, but not all the babies will need them. What I mean, temperature stabilization and monitoring. If it is mild form, we don't need. If it is severe form, it is very important point. But it is not about treatment of jaundice, treatment of hemolytic disease. It is a symptomatic treatment. If we need, we use it. If we don't need, so we are lucky we don't need it. Check and correct vital signs in all necessary options. It may be the use of assistant mechanical ventilation or CPAP equipment. It may be the use of vasopressors, doesn't matter. Stabilization of vital signs and monitoring. If we need, we can place the baby into the incubator. Correction of metabolic disturbances. Um, we need to choose the way of nutrition. Maybe the baby needs parenteral nutrition. It's also optional symptomatic treatment. Three basic methods of treatment include phototherapy, blood transfusion, exchange blood transfusion, and the use of specific immunoglobulin. Treatment of the hydrops must be started during the pregnancy because it's the most severe form and it must be diagnosed on time to save the baby. Early delivery of the baby is possible if a baby can survive. So if the gestational age is enough for babies surviving, we need to make early delivery. If not, we have an option of treatment during pregnancy. It is intrauterine exchange blood transfusion for the fetus. Also, some options like plasma sorption, like the use of specific immunoglobulin in case of RH incompatibility, can help sometimes trying to prolong the pregnancy. But if the baby can survive, we can make early delivery and then to treat. If it is a hydrops, we have only one option of treatment. It is only exchange blood transfusion. After birth or intrauterine exchange blood transfusion, doesn't matter, it is exchange blood transfusion. I remind you that baby with hydrops is having severe anemia, severe metabolic disturbances, and severe hyperbilirubinemia. That's why we have only one option. Also, for baby with hydrops, we need to help his lungs, so immediate intubation or use of CPAP. We must help to breathe. We must control kidney function, liver function, metabolic changes. We must remove the fluids from the abdomen to give the space for lungs, to, to give the patient opportunity to breathe in general. The use of specific immunoglobulin only for RH incompatibility, especially for RHD incompatibility. In other types of incompatibilities, it doesn't work because it's specific immunoglobulin. During pregnancy, it can be used on 28th and 34th week in case of RHD incompatibility. It can prevent or help to neutralize antibodies and to save the baby. Also is possible postnatal prophylaxis for mother. This immunoglobulin can be prescribed within 72 hours for RHD negative mother after giving a birth for RHD positive fetus. Management of pathological jaundice. So if you diagnosed the jaundice, pathological jaundice for baby after birth, you must check according to normals his bilirubin level, and you must assess the risk of this jaundice according to levels of bilirubin. In this table you can see American Academy of Pediatrics scale with risk zones. You see the age, you see bilirubin level, and the risk zone depending on the baby's age and his bilirubin level. To make it more simple, I think we have in the form of the table what you need to remember for exam. For exam, you need to remember indications for phototherapy and exchange blood transfusion for full-term babies with normal body weight. So the last line, indication for phototherapy, bilirubin level more than 15 milligrams per deciliter in the baby from 24 hours of life. Also, we must look how the bilirubin level changes. If after initiation of treatment of phototherapy, you don't see decrease in the bilirubin level, it's a reason to suppose the failure of phototherapy, and it's a reason to think about other treatment options. If phototherapy is effective, you must see decrease in bilirubin concentration in 2 milligrams per deciliter after 4 hours of phototherapy. Also another option, how the guideline can look like. I like this table, it's in micromole per liter, but I like it because it is visible, it is written what to do. You see age in hours, you see bilirubin level, and you can find. For example, we have 38 hours old baby and bilirubin level is 230 micromole per liter. So we found the age 36 hours, follow the row until we found the column more than 225 micromole per liter. Going down, what to do? To start phototherapy. So very easy to use the chart. Your guideline may look in different way, but indications are absolutely the same everywhere. Also, example of chart for full-term baby. Every day we measure the bilirubin concentration. When our measurement crossed the line of phototherapy, we start the phototherapy. If it crossed the line of exchange transfusion, we need to start exchange transfusion. How works phototherapy? Phototherapy, it is very interesting method and very useful method, very easy to use method. The idea is that bilirubin can be converted to soluble form under the exposure of blue to green light with a wavelength 460-490 nanometers. Photoisomerization, so structural isomers from non-soluble to soluble form under the exposure of this light. It's not an ultraviolet lamp. No, it's a specific lamp for phototherapy with very narrow spectrum of the light. So sunbathing cannot help the baby. Ultraviolet lamp cannot help the baby. We need specific lamp for phototherapy. It may look in different way. Here you see transportable lamp. Here you see it looks like an optic wave blanket. Standard lamps. This is not sunbathing machine. It's the lamp for phototherapy, the modern lamps for phototherapy with all necessary indicators, the climate control, so ventilator, everything. If you use standard lamp, we must follow the distance between baby's body and the lamp at least 30 centimeters, 25 to 30 centimeters, to prevent overheating and so for the baby. If we use like an optic wave blanket, it's safe. Very important is to close the baby's eyes because it is very strong light. The best regimen is non-stop regimen. So 24 hours a day, a baby must stay under this lamp. The duration of phototherapy depends on the bilirubin level. From what bilirubin level we started. For some babies, they need like 24 hours, 28 hours. Some babies need 2 days of phototherapy. It is individual and individualized and it depends on many factors. Very important is monitoring how bilirubin is decreasing. It is really effective method, non-invasive, very cheap, very fast, and effective. About the use of immunoglobulin, I told they use in the pregnant women and postpartum prophylaxis. Also, in some guidelines, it is very recommended. In some guidelines, it is not strongly recommended, only as an optional way to treat, but it's a specific immunoglobulin. It works only in case of HDN incompatibility. Exchange blood transfusion we use in severe anemia, severe hyperbilirubinemia, and hydrops. You see indications for exchange blood transfusion in the table. You must remember more than 20. For phototherapy, more than 15. For exchange transfusion, more than 20. Now I want to tell you a short case for better understanding. It is a case of minor blood group incompatibility. So we have a male baby who was born from the third pregnancy of a 32-year-old mother with gestational age of 32 weeks and 2 days and a birth weight 3.5 kilos by cesarean section. It was a third living child and was discharged without any problems 2 days after delivery. In prenatal history, it was learned that the mother received levothyroxine treatment in the last trimester of pregnancy because of hypothyroidism. At the follow-up visit on the third day after delivery, He presented with jaundice and bilirubin level by transcutaneous bilirubin detector was 18.7 milligrams per deciliter. Laboratory findings: total bilirubin 17.6, hemoglobin 15.7, blood group O Rh positive, direct Coombs test positive. The mother's blood group was found as ORH positive. That's why we checked minor blood groups, because we have, on the first look, they're absolutely the same blood groups, but why Coombs test was positive. And minor blood group check, you see the result. Mothers, E negative, babies, E positive. Indirect Coombs test in the mother and anti-E antibodies level in the mother and baby were positive. Considering the clinical and laboratory findings, a diagnosis of indirect hyperbilirubinemia related with minor blood group incompatibility due to anti-E was made. The patient was treated by phototherapy 28 hours without the need of advanced treatment methods, and the serum total bilirubin level was 10.8 after phototherapy. So it's a case of minor blood group incompatibility. That's why we have a double check, Coombs test for both, for mother and child, to exclude possible mistakes and to find the real reason of severe hyperbilirubinemia. Thank you for attention.